triple-negative breast cancer has really become more and more of a interest for those in the world. So I have had the opportunity in the last couple weeks to go to some amazing meetings, one of which was here at the CTRC talking about different immune therapies. And then last week I was honored to go to another research meeting in Arizona and talking about this. And this is the one area in terms of breast cancer that remains an interest for many folks. Not that all types of breast cancer are an area of interest. The things that you're going to hear today are a little bit about what we know in terms of how we define triple-negative breast cancer, and then how we are currently tackling it. But because of the research work and the things and efforts that are ongoing at centers like this and others in the city, we're beginning to look at novel ways to treat it so that it can be a much better outcome. Again, I don't know what your expectations are. I don't have the magic answer in terms of how to treat it from today's lecture, but at least it'll give you the fundamentals of what we understand today. I do best if I have interaction with you all. So, you know, we're getting this videotaped and all like that. This will be edited. So you all can ask me questions. This is really a program for you all in terms of understanding things. And I'm proud of you all that I have this many people come in and listen about triple-negative breast cancer today. But I think it's just a demonstration, if you will, of how much of an interest this disease is to many who are affected or who have family members. So again, welcome and thank you. So what is it and how do we treat it, right? Is that kind of what you were expecting to hear today? Well, we'll see. Well, first, some facts. The whole reason that many of us strive so much to work in this field in terms of breast cancer is that it is a very, very common disease. And I don't have a pointer, but basically for 2015, I only updated this slide for the United States figures. In 2015, it is expected that over 234,000 new cases of breast cancer in this country alone will be diagnosed. By year's end, 40,000 individuals will lose their lives to this disease. So if there's any reason as to why I do what I do and why I work so hard and why I have so much care and feel a privilege to do this work, is because the work is not done. And until we start to see those numbers of death going away, then we all have a job to do. Now this is the kind of stuff when I sit in lecture halls that we look at, and I guess I should have asked the question that I just did after this. There are different types. To the far right of the room, that you see luminal subtype A. You all see that in the back? And then you see luminal subtype B, luminal subtype C, normal breast-like cancer, ERB-B2, and basal-like. The disease entity that I'm talking about today is under that class to the far left called basal, and I'll show you information about that. Now, what is it? Basically, triple-negative is what it's not. When we talk about breast cancer in terms of subtypes, I just told you about A and B, and that has to do with different receptors. We're talking about the type of breast cancer that does not, when tumors are stained, so when a woman or man is diagnosed with breast cancer and the cells look like they're malignant, they then follow with staining that evaluates for doorways or receptors for estrogen, progesterone, and HER2. And this process is the kind that does not, with good staining, so the staining is not the problem, does not stain, does not have any evidence of estrogen receptor, does not have evidence of progesterone receptor, and does not have a presence of a receptor for HER2 new. Because it's negative for 3 areas, it's so named triple negative. Now the import of that is way more than what I just told you. But when we start to talk about triple negative disease, that's the first fundamental that must be met in order to determine if someone has triple negative breast cancer or not. And it's basically an absence, if you will, of those receptors. Because of that, in our strategies of treatment to date for breast cancer, we've relied upon looking for targets, things that are out there in the surface of the cell that we can say, we've got that, that's a unique feature to the cancer as opposed to the normal cell. Let's go ahead and use a medicine for that. We don't really have an anchor or a target. There's no way to sort of find something that's just out there to sort of reach. Now, one of the things that I don't have in the slide set that I had put in last night is there's a lot of things going on inside of the cell, and I'll show you a little bit of that in the slide in the present talk today. but there's really no obvious target right now to treat. So for the estrogen receptor positive patient, the classic thing is a tamoxifen or an aromatase inhibitor. Some of you all may be familiar with those kinds of drugs. But here we don't have such an opportunity. Or if it's HER2, we use a drug called Herceptin. One of the classic things back to sort of what they do with the tissue biopsy when a person's first diagnosed is they stain it for this type of material called cytokeratin 5-6. That's classic for a triple negative breast cancer process and for epidermal growth factor receptor or EGFR, and that falls under the basal cell. I promise you I'm going to show you a picture of what basal cell looks. So just hang in there with me because I am going to show you what that looks like. But that's another key factor in terms of a diagnosis for triple negative. So not just the absence, if you will, of the receptors, but those features are there as well. About 75% of tumor cells that are called basal-like, remember that left side of the figure that I showed you? 75% of them are triple negative. Now, basal cell type triple negative breast cancer is the key one that we talk about in terms of its biology. There are, as you'll hear, a little bit more about just because you have, quote, triple negative doesn't always mean that triple negative biology is the same. And so this comment that only a large portion of triple negative are basal-like is important for you all when you think about prognosis and outcomes and survival rates. So back to estrogen and receptor and progesterone, visual. We talk about an anchor. Notice it's at the surface, at the outline of the cell. It's out there. ER/PR, doorway. You came in this room through that doorway. Or HER2. We've now, because we know about those receptors, and it's not a new thing, been recognized for decades, we can use something, if the tumor, this is the tumor cell right here, and the nucleus is the blue, if we can do things, since we know that that signal will tell that nucleus to divide and grow, if we do something to starve that receptor with blocking it, then tumor cell growth will stop. That's been our strategy for ER positive and PR positive disease. Same thing with HER2. There's an anchor. There's something out there that we can target. We see it, and we can use medicines for it. Conceptually, do you understand what I'm saying? Right? Okay. In contrast to, we don't have anything. Now, what I think a lot of people had thought, and that's what I'm learning with the research that we're doing, is that there ain't nothing there to target. You know, just use your best thing, and that's what you use. And it's been pretty successful, I'll add. But it doesn't really have sort of that. So that's where the triple negative receptor, triple negative breast cancer. Now, I still haven't shown you a picture, but it's coming. But basal-like, just remember those terms, refers to a feature that these tumors appear to look like the basal cell membrane of the tumor of the milk duct. Okay, so it's named basal cell because those cells, when they look under the microscope, it looks like those, and they line the milk duct. And that's part of the normal architecture. Like any cell, though, it can become malignant. In general, tumors that arise from this area have previously been described as aggressive. What do I mean? Fast growing, spread early, higher grade, when we grade it in terms of how many mitoses and nuclear changes that look really large or abnormal, higher grade, and they have a faster rate of spreading. So that's what we mean when we talk about basals. When we talk about the basal cell, and I think for those of you who are sitting closer, you can see these large, very angry, large nuclear pattern along the basal cells. And this is staining for all of them. This is a special stain just to verify that it's a basal-like process. Very large, very open pattern in terms of the chromatin pattern. Very irregular and lots of mitoses. Mitosis means growth, division, therefore the tendency to spread. So that's pictorially what I was trying to present. Now, what we still, particularly as those of us who do oncology work, we have been able to sort of discover that those subtypes, A, B, luminal A and B and HER2 and basal and all that, there are just walking the door. You don't get to choose if you have breast cancer, having breast cancer, right? But you don't get to choose which type. But just based upon the type, that may influence the biology and outcome. So this is a slide from a long time ago, back in 2005. So not 1800, but a long time ago. In oncology, that's ancient, 2005. Something 6 months ago in oncology is long. But the idea behind it, the gist that I want to do, and I don't think that these project very well to the back, because even being close, I don't see it. This is actually supposed to be pink to represent basal, and then you have your ERB here. But what these are recurrence curves in terms of how long it takes before someone will have a recurrence. So they all start up here, but how fast those different subtypes, just by having an ER positive or HER2 positive breast cancer or triple negative, just walking in the door, that is your diagnosis. How fast overall those cancer cells are likely to reoccur and metastasize. Notice that the basal cell is here. Got it? And this is just a survival. The survival is not better. The group that does the best, they don't all live long, and that's various variables, as you might understand, but this is just to give you a concept of how much more poorly the outcome and survival is just walking in the door and having a basal cell or triple negative breast cancer, right? Not very positive, Dr. Wilks, aren't you being mean, but you're here to learn. Now, what we have begun to discover, and this is a challenge for us in approaches to treatment, is now that we've got this all worked out, that there's different subtypes of breast cancer, so we use different types of applications of therapy, we just assume if it's triple negative, like ERP and HER2 negative, that it's triple negative and that's the biology. That is not true. Remember, cancer is never going to be a consistent logical process. It's very heterogeneous, and so is triple negative. So just because one has triple negative breast cancer and have heard that there's a very poor outcome, perhaps an aggressive tumor and all these things, that's not always true. Like in everything I deal with cancer, there's no predictive pattern. Again, further slides on what it is. Unlike most types, and I've shown you this by that graph about the survival rates, the tumors that grow slowly and have what we feel are favorable outcomes, with the hormone receptor positive breast cancer being the prototype for that, these are the individuals whose tumors have a higher risk of recurrence, usually within 2 to 5 years of diagnosis. But what's different, it's kind of one of those things you pay up front. If a person has triple negative breast cancer and they have now gotten to their 5th year anniversary, we rarely see those patients ever have recurrences later. Some people have talked about breast cancer as a chronic disease. Whereas if I have a lady who has ER positive disease and she's node positive, meaning she's got lymph nodes that are involved, and she's gone through her first 5 years as being good, I may worry a lot more about her for a later recurrence than someone with triple negative. Triple negative, it's just kind of one of those things. If you don't get it and it doesn't get taken care of, it may reoccur early. But if you can get it and take care of it early with proper therapy, with chemo and surgery and radiation, and that person makes that 5 year, they're very unlikely to ever die of breast cancer. And then I've already established that the metastasis rate and survival rates are low. When analysis have been done, and I discovered this a long time ago as well, is that if you just have, again, someone who has triple negative versus other subtypes, and you look at 5 year survival rates, stage for stage the same, the individuals who have hormone receptor and HER2 negative tumors have a lower survival rate, 77%. It's not zero, but 77% 5 year survival rate compared to other types of breast cancer survivors with other breast cancer types, with it being 93% 5 year survival rate. It's almost a 20% difference just by the different type of breast cancer you have, stage for stage, 5 year survival rate. Does that make sense? So I've already established that it's a rare type. So remember I asked you all early, what's the most common type? Ductal is. But in terms of like ERP or HER2 positive, triple negative, well, you know triple negative is not the most common type. What would your guess be? What's the most common type for the receptor status? Anyone have a guess? ER positive, that's right. See, now you get to, no, I'm just teasing you, you get the star of the day. But that is the most common. 2/3 of women diagnosed with breast cancer will have a hormone receptor positive breast cancer. That is the most common form of breast cancer. This is more rare, but in spite of it, because of our challenges, it is the one that's getting the most attention in terms of how we approach it. Classically, it's younger women. When we look at breast cancer as a disease, it is a disease usually of older women. I'm saying older, not old, because a lot of people get on me about being, So women who are above age 60 or 70, they're more prone to have hormone receptor positive disease. Now, I have a lady, several women, all of us do, that was diagnosed with triple negative breast cancer in her early 80s. But the majority tend to be more young. Young is your age, whatever you want to come up with, but we'll say less than 50, okay? But, you know, I'm in my 50s now, and so there you go. Women of African American descent, we do not know why, but that's a true observation. Proportionately, too, it's more significant because Caucasians generally are more at risk for breast cancer, and other ethnicities are fairly more rare. But of that rare group, of that proportion, more of them are affect African Americans. And then this BRCA gene mutation, I do have a slide to kind of talk a little bit about BRCA gene mutations. When individuals have triple-negative breast cancer and you look at the gene mutation analysis, about 15 to 20% of them will carry a gene that makes them susceptible to having breast cancer. So anyone who's currently diagnosed with breast cancer today that has triple-negative breast cancer, we know to check for the gene mutation. And I'll go over that a little bit more, which is on this slide. So anybody know about BRCA1 and BRCA2, raise your hands. A lot of you, wow, okay. Well, then I don't really have to tell you what it is. But basically, the genes that we inherit, we get a couple that we inherit that protects us normally from getting breast cancer. They're called tumor suppressor genes. One of their wonderful jobs is to keep us protected from getting cancers. And and chromosome 13 and 17, those are the genes that carry, the chromosomes that carry the genes for the BRCA mutations. There can be alterations. We use the word mutations, but the DNA is changed. When the DNA is changed, the message for protection is gone, and therefore individuals who inherit these mutations are more susceptible to developing breast, ovarian cancer, and sometimes pancreas cancer and other cancers as well. So that's what we talk about. Now, and most of us, and you all, many of you didn't come to the genetics talk last month, though we'll have a lot of things on our website with our genetic counselor to talk about it. There's much more analyses than BRCA1 and BRCA2 that are screened for today, but those are the ones that we most commonly associate with triple negative. So I just wanted to make sure that you all know that these are the two genes that we're talking about, and individuals who inherit them are more prone to the diseases mentioned there. And pancreas cancer is coming up to be more, particularly in the BRCA2 mutations, more so than we recognized before. And when someone has inherited a gene that has an alteration, their lifetime risk of developing breast cancer is greater than 50%, which is not the norm for the population. So that's what that means in terms of mutations. And then again, the criteria that we use for looking at who might be worthwhile to test and who might be a carrier, someone diagnosed with breast cancer before age 50, certainly before age 45, having a personal history of an ovarian cancer, that's not fair, having ovarian cancer and then going on to have breast cancer, or having someone in your family that has ovarian cancer, that in and of itself is a risk of a red light if you have breast cancer to check for BRCA gene mutations. If there's a family history of male breast cancer, that's a red flag for potentially a gene mutation being present. Ashkenazi Jewish ancestry. I met a lady the other day, I think she has 4 or 5 relatives who have had breast cancer. She wasn't diagnosed young, but there's a high prevalence and high death rate amongst her family members. So that's someone definitely want to test. And then, of course, the triple negative. Now, this is the slide I have replaced, but here it is. Okay, so I told you guys that there's nothing to target. What this slide is to show you, and this is not as complex nor highlights the things I'm going to talk about with treatment next, but it's just to give you an understanding of, I always tell people this and people laugh at me. Have anyone ever seen or watched or read the book, Important Here's a Who? I got to get you guys, because you all look so serious right now, and like, let's get some laughter going on here. And for those of you who come to other lectures, you may have heard this. And what was the situation? There was a dust particle. And Horton was like, I hear people or whatever, and they were like, no, 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 and you know, he's got the big ears. But it turns out he was right, because there was a village of people, and he was trying to save their lives. Remember that story? Do y'all, right? Is anybody with me? Okay. So what I want to make you understand, and it's a silly way of trying to give you an understanding, we look at the cell externally and we think that that's just a small, 100 micron size. It's got a lot going on. And just like you all probably came here through streets and highways, there's a lot of streets and highways in the city that we call signals. Signals because they send messages to the nucleus to divide and grow. And when that cell has become cancerous, that's not a good thing. You do not want to signal the cell to grow, because then that's where cancer develops and cancer can grow and spread. So this is just one of many ideas, and it just gives you a concept, not quite the slide I wanted to show you all because there's way more to it. This is what goes on inside of cells. All of those, think of them as street names: RAS, PI3 kinase, P10, RAF, MEK. The closer it gets down to the nucleus, including mTOR, there's medicines now to target that. Those send powerful messages if they're amplified or altered in their signaling to tell that cell that's become cancerous to grow and make more cells like it. And we now know that. Because we know that, that's where the energies are being placed beyond, and you'll hear some basic things about chemotherapy. That's where research is going to try to target those areas, because the closer you are to the nucleus, like I'm next to you, and if I wanted to possibly do you some harm, which I would not, you're a nice lady, I would definitely have more of a punch here than if I was sitting back where Norma is in the back near the wall, and she was trying to send a signal through this group to hit it. The punch would be less, right? So the closer I am to the money spot where the nuclear division goes, that's where you want to go. So there's a lot of strategies, not only to hit one or two or one of these targets, but maybe hit both systems so that you really stop the message to go. That's where, if you can get the gist of that, that's the importance of that slide. But this is where we are today in 2015, March 12th. We still approach triple-negative breast cancer and a lot of breast cancer in this way. I've been doing oncology now with breast cancer. I did transplant medicine, and our still fundamental primary issues, so there's immune therapies and all these neat ways of treating today that we're keeping up with. We still realize that cancer cells go through a division fast. And I talked to you about mitosis and things with triple negative earlier. You can imagine this is a disease process that does grow quickly. So our main strategies still rely upon cell division, where you have the normal cycle in terms of, you know, your growth phase, and then you go into a mitosis, and then you have a resting period, and the cell grows once the cells have been formed. You just have that, and then synthesis. I mean, you just have this continued cycle of normal. This is normal. But the tumor does that too. So we use medicines that really attack different phases of this normal cell cycle division with chemotherapy agents. And many of you all have gone through chemotherapy, I think, here in the room, so you understand that because of some of the effects you've gone through. And what we're trying to do at times with chemotherapy is to stop, at certain points, that cell cycle. We don't want to do it for our normal cells, but it turns out that cancer cells go through division much more fast and often than our regular cells. So because of there's that difference, we can oftentimes make that cell that's going through division more vulnerable and susceptible to chemotherapy that targets the cell cycle, but then we can recover. Classic example, we lose our hair with chemotherapy, but most of us, once the treatment is done, the hair grows back. But those cells, we believe, the cancer cells, don't. That's an example of what I'm trying to say in terms of things. Does that make sense? You guys are so serious, so I don't know, it's just kind of hard. And then this is just other things. I think I had deleted this too, but just to kind of remind you of the different things I've already said about just all of the things when you talk about BRCA genes and triple negative and how similar they are. And I think that the point is that when we look at different types of strategies for treatments, we do look at the fact that there are similarities between individuals who have hereditary gene mutations in the BRCA1 and 2 to triple negative in terms of that basal cell-like. And that's really the only point of that slide. But back to the chemotherapy, the things that many women today and men who get triple negative breast cancer, and actually just a interesting tidbit is that men rarely get triple negative breast cancer. You know that there's male breast cancer, 1% per year. 90% will be hormone receptor positive. So it's very rare to see men with triple negative breast cancer. But nevertheless, they do, and we treat it the same way. So you may, if you've had chemotherapy, you may recognize some of these drugs. We use our best drugs. Now, not necessarily nice drugs on people's bodies, but our toughest drugs that we know that kicks that division cycle's butt. And we use drugs like adriamycin. Everyone always tells me the red devil. Yes, always hear that. Anthracyclines, taxanes like Taxol, Taxotere, and Cytoxan. And there's beginning to be emerging reports about the usefulness of a drug called platinum. And that's a real interesting agent because that does affect the DNA structure and repair system very, very much more exquisitely than some of these other drugs do. So there are beginning to be people who are beginning to use drugs like cisplatin and carboplatin when people are first diagnosed with triple-negative breast cancer before surgery is done. But as I've read the literature in preparation for this talk today, it's still not conventional that we should be using that right away for someone who's just been diagnosed. But if it recurs, if the breast cancer reoccurs, I have a patient who I recently treated with a medication called Gemzar with carboplatin, because these drugs have been shown to be helpful to fight the triple-negative breast cancer. But then there's other targets. Let's see. I'm going to be as kind of surprised as you all in terms of what's going to come up next. So the key thing, particularly because I know some of you are in the midst of your treatment or just recovered, so I've got to be really positive to let you know that most times using those awful, harsh chemicals works. Because triple-negative breast cancer is a disease that is dividing and going through division often, and the repair systems are impaired, so that if we kick it, that's why these treatments with mixing up the drugs and the different schedules and weekly treatment versus every 3 weeks and using these different chemicals at different times are utilized, because most times we actually do it enough to kill the cancer, because it is very, very responsive the earlier that you treat this disease. If you give chemotherapy and you tackle it before resistance pathways develops or other signals pick up, you can actually destroy every remnant of the breast cancer. And this has actually now been shown. There are women who get chemotherapy prior to surgery, before the breast cancer residual is removed, before the mastectomy or lumpectomy is done. And we have followed women who get these chemotherapy treatments up front. They may have a mass. I have a lady who's recently in my practice. Her tumor was bigger than my fist in her breast. And it was triple negative. She's already got lymph node involvement. And my expectation with the treatment that she's getting, very similar agents as I've mentioned, it may shrink down to what we call a pathologic complete remission, where there's no traces of that disease at the time of surgery. So we know that this, if you get it early, you can kick it. It is a harsh treatment, but it usually is very, very effective. And so, though many of you probably have had your surgery and then do chemotherapy, there is maybe a paradigm shift, so to speak, in that we may begin to start doing, even if it's a small breast cancer, lymph node negative, but triple negative, we may start to utilize these drugs up front before surgery is done. It gives us some ability to shrink the disease in the breast, but before it sends off cells in the circulation. And also it gives us a predictive model, because if there was not a good response, then you know that there may be other strategies that you may have to employ, because this may be a resistant type of tumor to those kinds of medicines. So there's a lot of things going on in research about that. Am I making sense? Yes. You guys probably are just saying yes because you don't want to say, no, I don't get that, Dr. Wilks. But if you don't get it, please let me know. So now, that's preoperative therapy. When we use the word adjuvant therapy, so treatment after breast cancer is removed, either through a mastectomy. Someone will opt for a double mastectomy for prophylaxis and things. But whatever the case, the primary tumor is removed. Then after, so as an adjunct to that, then we talk about adjuvant therapy. And this is a disease, many of us will say, like people come into my office and they say, I've had my surgery, the surgeon told me they've got it all. Why am I seeing you? Because I don't have any cancer. But there may be certain features, like they might have a tumor that was 8 centimeters, even though it was removed, and I'm using extreme, or there may be lymph nodes that had cancer cells in them. Those might be indications to say, well, yeah, that may be a more higher risk person, let's use chemotherapy. But in triple negative breast cancer, it can be a 1 centimeter node clear. We will still use the same treatment that we would use for a more higher stage or more volume of tumor burden in these individuals. And the current agreement, I think, some people still use it even for smaller tumors than that, but 0.5 centimeters. And I do get to see people, because of mammography, I'm seeing women who come in with tumors that are 8 millimeters or 5 millimeters big. But if it's over 5 millimeters, most of us are employing those same treatments as if it was a stage 2 or stage 3, which advanced higher stages for chemotherapy, because of the biology, because of the aggressive nature. Doesn't matter. And individuals who get those treatments, we know do better. So if individuals get chemotherapy who have triple negative breast cancer, their recurrence rate is reduced by 55% compared to those that don't get it at 26%. Now, it's not 100%, but you can see the difference, right? And it also impacts overall survival in a significant way. That's why we give people chemotherapy, even when we don't see any evidence of cancer. Does that make sense?
Yeah. Like lymph node negative?
Lymph node negative. So we're talking about nodes are clear, and this is just tumor size. Absolutely. Because we know in the node positive, that's already potentially a risk factor for recurrence. And then I've mentioned these drugs already, the types of medicines that we use with their generic and brand names. We're actually doing some work with a drug that targets the androgen receptor. I didn't mean estrogen, androgen receptor. But there's a lot of research going on. So angiogenesis, when tumors grow, the reason that they survive, in addition to all the things that the tumor does in terms of mutations and changes, is it develops new blood vessels. So our nutrients that we take in are also used by the tumor. Get that, parasite. So we know that if you have evidence of, there's a marker called a VEGF, vascular endothelial growth factor, you can actually measure that in tumors and different components. That's a factor that tumors secrete to build up new blood vessels. If that is a higher secretion of that they're going to have a more unfavorable outcome in terms of growth because they're utilizing a system. So we have drugs that actually several drugs, but one of which was very famous and still is utilized, called Avastin or bevacizumab. And that actually inhibits angiogenesis, stops the new blood vessel formation, just as a specific thing. So when people come to me and said, if I eat this diet or if I avoid glucose, will that help me? Tumors use a lot of things to grow, guys. So I don't have any problems with your diet and all that and what you want to do, because that's in your power. But it's not only that. They form their own new blood vessels. The other thing is, remember how I told you all that there was no receptor? So you have to pretend like Barney. When my kids were young, they used to watch Barney and use your imagination. But on the edge of the cell, the surface of the cell, there's different receptors that we didn't talk about because I said that there were none. Remember I said triple negative? But there is a family of receptors there called epidermal growth factor receptors. And that's a hot area of research in triple negative breast cancer because we have medicines that have been used for years in head and neck cancer and colon cancer that target that receptor. And the whole idea is if you go through that door, it tells that tumor cell to grow. So if you can block that receptor signal to the nucleus, cancer cells stop growing. Does that make sense? So that's an area of research as well. The androgen receptor, that's really been a fascinating thing. I had to get my mind wrapped around that one because I've always thought about progesterone receptor and estrogen receptor. Well, there's another receptor that's more internal, and in the slide I didn't show today, internal, there's an androgen receptor along with other receptors. Remember I showed you the mTOR and RAS and MEK, all of those PI3 kinase? Well, that's another area that is present particularly in triple negative. Now, I don't think I'm going to be violating any proprietary information to let you all know we're doing a phase 2 study, and in order to be on the study you have to have triple negative disease, but you have to have the tumor tested for androgen receptor. And this is only for women, just in case you guys are like, I'll sign up, only for women who unfortunately the cancers come back, so it's for metastasis. But androgen receptor, and I can tell you, and in their experience, they think over 80% of the time that the glucocorticoid or androgen receptor is present. Like, remember I told you, no receptor? We got another receptor. Now, what do we do when we know we have a receptor? We find drugs that kick butt. So we have a drug that's being studied that actually targets the androgen receptor and using it with a standard chemotherapy. And what we're going to see is that there's an improvement in survival rate. These are the kinds of things in research that are going on that make sense. Takes, you use your model in terms of what has been successful before, and here we are. And the target is a pill. It's amazing. If the patients are tolerating the treatments well. We did early phase 1 work in that. So isn't that, here we're talking about triple negative, but there's that androgen receptor. Has anyone ever heard about PARP inhibitors? You will. You will. No one? Okay. You guys are going to have to come to our annual breast cancer conference every year, because you're going to have to learn a lot more than what you guys know. But PARP inhibitors really took a lot of attention several years ago, and then it died out. But in ovarian cancer and other cancers, it's actually, there are drugs out there now that affect it. Turns out, guys, cancers go, do division. Remember I showed you that? But what happens when there's a mistake? in the DNA. It's repaired. Why we don't have more diseases is because from the time we're born to the time that we're living now, it's because the DNA, there's mistakes that happen all the time. I mean, do you not make a mistake after been working like for 20 hours, right? You're sleep deprived, right? So imagine after years, our DNA is replicating, makes mistakes. Well, the reason why we don't see as many mistakes and as many diseases is because there's repair mechanisms. And cancer cells have those too. But we don't want them to repair themselves, right? Okay. So PARP, poly-ADP ribose polymerase, is what PARP stands for, is an enzyme that repairs DNA. It's just normally there. And anything that damages there's been a mistake, or I did an adenine instead of a cytosine or thymine versus guanine. Oh, we got to fix this. Those are the enzymes that fix our DNA, but you don't want it to be fixing in cancer cells. So when we give chemotherapy, and I can promise you, anybody who's had chemotherapy, here in this room or not, will say, I feel like sometimes I've gotten a bomb, Oh, my body, everything is just zapped and just everything is off. We kick it with these chemotherapy drugs. And while I've got it knocked down, I do not want it repairing, right? Because that's exactly what's going to be done, because it's trying to survive. And so we recognize that that's a vulnerable situation, and particularly in individuals who had the BRCA1 and BRCA2 mutations, they already had sort of a hit because they have an alteration in DNA that makes them susceptible. So you hit them with the drug, they're really struggling to repair and survive and grow. Right? So these drugs have been shown to interfere with that repair mechanism. Yes, we found it, because they inhibit that enzyme repair. Does that make sense? And then aliparib, I think is the name of it. I don't know the brand name of it, is approved right now for ovarian cancer as a PARP inhibitor, and I think there are other drugs out there in the market as well. So we thought we had found a PARP inhibitor for breast cancer, but as it turns out, the drug that they thought was a PARP inhibitor was not actually a PARP inhibitor. Again, science is struggle. I know that frustrates everyone, but you got to make sure that the drug that you have is really working towards what you thought it was supposed to be doing. And if you don't have the mechanism of action, sometimes you'll be disappointed that the drug is actually not effective. And that happened several years ago in a phase 3 study. And I've talked about the epidermal growth factor receptor. Again, that's out there, just like that estrogen receptor, in a family of epidermal growth factor receptor group. This is HER1, HER2, HER3, HER4. This is HER1, and there's drugs in the market. Erbitux that we use in head and neck cancer. Also, cetuximab is its generic name. We use that in clinic. So we have people who are studying that drug in people who have basal cell, basal-like breast cancer, triple negative, for treatment management. I was at a fascinating talk last week. Metformin. Has anyone heard about metformin and triple negative breast cancer? Has anybody heard that? That's a study that was actually enrolling at CTRC here in San Antonio. Guys, don't think always got to go to MD Anderson. We got a lot of great centers here in San Antonio, a lot. And one of the goals of our foundation, organization, is to educate you all about the existing delightful state-of-the-art treatments that exist in this town. But anyway, that study is now closed to enrollment, but I have a patient who was able to get on it. And the idea is that, we talked about all these different things that the tumor uses to grow. Well, insulin growth factors apparently can work in a way for tumor metastasis and growth. And so the idea is if you can shut down the insulin signal for tumor cells that need it, that might actually antagonize tumor cell growth. So here we use a common generic drug that we all use for diabetes, and metformin is being looked at. Again, it's a tablet. Doesn't apparently, in people who have normal glucose levels, bring their glucose down. So it's interesting. It doesn't harm you in terms of making you hypoglycemic. But actually, this is another strategy that's being looked at to see if that drug, at least in that one target, may be beneficial for women who face this, or individuals who face triple negative breast cancer. What I'm presenting to you is just where research is. With us finding vulnerable, more than just I don't have an estrogen receptor or HER2 new, what else do we know about triple negative that's specific? What do we know about the signals inside? What are the different things that are activated and amplified? How can we target it? And I promise you, like in most things with breast cancer or cancer in general, doing one target probably ain't going to be the answer. It's probably going to be a combination of things. But what I'm trying to highlight to you all is that there's a lot that makes sense, doesn't it? that is going on to try to improve the outcomes of survival. And most strategies for breast cancer, aside from the upfront chemotherapy that I mentioned, the neoadjuvant, use those treatments and apply them to people who've recurred. Remember, I told you the majority of folks with triple negative breast cancer, given proper treatment, they do not recur. They live and are survivors. But for those individuals who do reoccur, then we know we got to sort of come up with a novel way. And these are the kinds of measures that are being done amongst others. This is just a sampling that are ongoing that really make sense based upon what we're learning scientifically. These are the kinds of things like the Whoville that are happening inside the cell that we now know. So to conclude, what I've just said for the last 40 minutes or so is triple negative breast cancer lacks expression of commonly tested receptors known as estrogen receptor, progesterone receptor, and HER2/neu. You've now learned, though, I'll add, that there's other receptors that we didn't realize that might be important. The biology of these tumors appear to be similar to basal-like breast cancers, which have a high association with gene mutations. Not all of them, but about 15 to 20% of the time will have a BRCA1 and BRCA2 mutation. And chemotherapy, yes, 2015, March 12th, I know what date it is, March 12th, 2015, chemotherapy is still the main way that we attack it because we're very successful with it, even though it has some harsh chemicals, admittedly. And because it reduces recurrence rates, improves survival rates significantly. But for when those individuals have cancer, despite those measures done, reoccur, then it remains a challenge to find improved ways to treat individuals with this disease. And I've tried in this talk today to give you some hope, but also some understanding of what really is being studied in all the centers that do research in town, novel ways to determine better ways to look at the signals, what are the drivers of cancer. Just because it's there doesn't necessarily mean it's making that cell grow. So we have to find not only what is in the path, what's in the highway, where are the exits, but what's the driver for that cell to grow. And then we target things like angiogenesis, which is always there, EGFR, androgen receptors, insulin growth factor pathways, DNA repair systems, stop them repairing that damage that the chemotherapy induces so that we can have improvements in survival and improved outcomes for this very rare form of breast cancer. And with that, that's what I wanted to share.